slides. There we go. Right, okay, we'll go backwards after. Do you want to come take over the
Sure. That would be we have a few slides.
And then we'll have Carmen next.
Great. So this is just a few slides pulled out. At the Alaska Resilience Initiative, we convened, we're a statewide collaborative. So people from all over the state came together to create a curriculum for doing training for different systems on trauma-informed approaches and how adverse childhood experiences affect educational or health outcomes and what to do about it in the classroom or healthcare, et cetera. So this is just a few slides pulled out from that curriculum, which you are able to access through our website. It's akresilience.org. You can find all that. So the basic principles of a trauma-informed approach are moving away from a sort of what's wrong with you and a more punitive approach to a compassionate and curious approach of I wonder what has happened to you and how can I help? And by what has happened to you and how can I help, sometimes that means screening, sometimes it doesn't. But it means having that lens of understanding, realizing the presence of trauma and how common it is, right? Realizing that the majority of Alaskans have experienced at least one adverse childhood experience, that it affects people's health, recognizing how it affects all individuals, including ourselves. So anything that we do as professionals, as healthcare providers, as educators, is about treating patients, clients, et cetera, with it, realizing recognizing how trauma affects them, but also recognizing how it affects us, right? Staff level, administrative level folks. Responding by putting that knowledge into practice and resisting re-traumatizing people. So creating situations, trying to remove situations in our healthcare systems that create power imbalances and that cue trauma, that reduce those really common triggers of trauma, and try to put in place the principles of a trauma-informed healthcare approach, which are safety, right? Physical and emotional safety, trustworthiness and transparency. So this is like clearly communicating things beforehand and writing and upfront verbally, following through on your word, right? Being clear and transparent in your communication. Collaboration and mutuality with your patients and at a administrative level between staff and administrators. Empowerment, voice, and choice. So patient-centered care, patients having a voice in their care. Peer support can be a way to offer support that removes stigma and that is very effective when people are able to get support from someone who has gone through something very similar to what they're going through. And then embedding in everything you do that awareness of cultural, historical, and gender issues. So having an equitable environment. As my colleague in California says that if it's not racially just, it's not trauma-informed, right? If people are coming to a space that thinks about trauma, but then they're experiencing discrimination in that space, right, that's going to be traumatizing for them. So making sure that we have safe, welcoming, trustworthy, collaborative environments for all patients, regardless of their identity. That's why with the Alaska Resilience Initiative, and you can find this one-pager on our website, we talk about culturally responsive trauma-informed. So we have just a one-pager of what those principles are, very similar to this. So those are resources. And then we get to hear from these providers about what it really looks like in action. Thanks.
Great. Carmen. I think we're gonna hear from Carmen, our patient, next. Do this, we're gonna come out of the PowerPoint presentation and take the sheet here with us. Carmen, stop sharing. Share.
Oh,
That's exciting. You share. There we go. So I can see Carmen. Can other folks online also see Carmen at this point? Okay. And Carmen, it looks like your microphone is muted. You unmute yourself and join us that way. We can't hear you, I'm afraid.
I just unmuted you, so you should be good to go.
Okay, I was gonna say I'm on a phone, so I don't know how to unmute myself.
We hear you.
just turned up the volume, Carmen. Can you introduce yourself?
Hi, my name is Carmen Monagold.
We're having a problem with our sound. Excuse me. Carrie Ann, I think that's your machine.
Okay.
Thank you for your patience with our technical new experiences. This is the first time we've offered a Zoom option for this call for both our presenters and our participants.
My computer is all the way up. I wonder. Oh,
Let's try again, Carmen.
Can you hear me okay?
Better? Yes, thank you.
Okay, my name is Carmen Monagold. I was born and raised in Kotzebue. I have had a long history of trauma ranging from sexual abuse to bullying severely. I basically raised myself from a very young age, always worrying about food security, safety, the feelings of abandonment. And once I got past all that, I thought, okay, I made it out, right? I had married to a state trooper. I have a great life. I have 4 boys that I'm, very proud of. And I went to school. I got my associate's degree. It took me 10 years, but I got it. And I got my dispatcher's license. I was a manager of an airline, and I was right where I wanted to be in life. I had kind of defied the norms of the women's role of, staying home and, providing the household stuff. And I went out and I learned how to hunt, fish. I mean, I was doing what I loved to do, and I was proud of myself. And I hunted for elders. I provided for people that couldn't hunt for themselves. And so I was really where I wanted to be. And then I hit 35 and my world started falling apart. And I was just like, what the hell's going on? I thought I was having allergic reactions to food, and it ended up being, and I thought I was going into anaphylactic shock. So I'd rush to the hospital, they'd give me whatever they give you for that. And they sent me down for testing, and it turned out that I had vocal cord dysfunction, which I had never heard of before in my life. And when I started researching vocal cord dysfunction, there's 50 million reasons what could trigger you. So how to deal with that, and I'm freaking out because I'm working long hours, 14-hour days, 16-hour days. And what I had realized is that in my job, there's 5 pilots on, 5 pilots off, and they switch every 15 days. Well, the one set of pilots, I was like in an abusive relationship with 5 people. And I was putting up with stuff from these men that I wouldn't even let my husband treat me that way. And so we were in a constant conflict. And what I had realized was that they were my trigger. And I ended up having to quit my job because every time their shift came on, my throat would close, I'd quit breathing. And I had to eliminate stress. That was my trigger for vocal cord dysfunction. So, being an independent person that I was from a very young age, knowing that I had to take care of myself, not being able to provide financially for myself was horrifying. And even though my husband was fine with it, I wasn't fine with it. And then I noticed that I'd start playing a game, like, a competitive game, and my throat would close. And so my life went from this broad place to just living in a little bubble. My mental health went to hell. Suicidal thoughts came, depression came. And then I started, like, I've had back pain since I was 12 that nobody could explain. And I was guaranteed that my back would give out at least twice a year from the time I was 12 years old. Well, I started having severe back pain. I started having myofascial pain in my elbows. I had to have surgery on both elbows. I started getting ablations done because every time I went in to check on something, whether it was an MRI or a CAT scan, or everything came back healthy, and I was devastated. I mean, it was something that couldn't be fixed, and I didn't know what the hell to do. And for somebody like me who always has to be in control, I had absolutely no more control, and my life was going to shit. And so I started going to therapy because I was so worried I was going to kill myself. And I wanted to get some semblance of who I was before, And I'd done some research, and there was an EMDR therapist in Anchorage that I would fly down, pay my own ticket down, and go see this guy. And he told me to go, to a bookstore or, a library or wherever, and get a couple of books on mental health. And so I went and I found Childhood Disrupted by Nakazawa, and that book changed my life. It changed the way that I looked at my life, because it was like this woman wrote this whole book about me, and it finally dawned on me that everything in my childhood finally reemerged as all these pains that were moving all over my body. I mean, I have knee pain, I have ankle pain, tomorrow I could have who knows what kind of pain. And my triggers are stress. And, I was so blown away, because as a trauma survivor, why the hell am I going through this again? I've survived it, I thrived, and now I have to go back to all these childhood frickin' hellholes that I lived in to try to get myself better, to get rid of the pain. I'm on pain pills all the time, and now with this whole opioid crisis, they're talking about taking my pain meds away, and that sends me into a whole new tailspin because I haven't figured out how to stop my pain. And I am paying the price because of these drug addicts or whoever, wherever. So I'm freaking out, right? Which causes more pain because I'm in a state of uncertainty. And I've been going to therapy. I see a psychiatrist, I see a therapist, I see my primary care doctor. The latest pains that have started that nobody seems to frickin' tell me an answer for is that, pardon my language, but it feels like somebody is hitting me with a 2x4 in my frickin' vagina. This is my latest development. Yay me. And it comes and it goes, and I don't know when it's gonna get better. So I'm going to my therapist, and I'm like, okay, I know that there's supposed to be a way to fix this. Well, they tell you, oh, if you do these steps and if you do these things, and well, you know what? When you're at the level that I'm at, you can't just tell me I have to do something. I need somebody to guide me because I don't have any self-motivation anymore. I am on 20-something pills a day just to keep me able to wipe my own ass. And when you look at all my scans, the only thing I have wrong with me is a bulging disc. Isn't that amazing? And I'm at a level 7-8 pain every single day. So I hope that one of you miraculous people out there someday finds a way to help guide us, because the trauma-informed care for children is so important. But there are so many of us adults that are suffering, and there's so many more that don't understand why they're suffering, why they have all these pains. And I was thankful that I had that aha moment, you know, of realizing that everything from my childhood is causing all this stuff. But how do I get back to the human I was before? Because right now I feel like a corpse that's trying to survive by my toenails for my family, for myself, because I want to live. I had a great life, and I just coming here and being able to speak in front of you people, I had to take Valium. My throat's closing. I'm gonna have my throat be swollen for 3 days because that's how long it takes to recover. But I feel so important, and I believe so strongly in what you are doing. And I hope that it'll help someone in the future not to become who I am. And I hope that somebody will figure out a way to help people like me. And I thank you for your time, and I don't know if I explained it in the best way that I could, but thank you.
Carmen, thank you for sharing that with us. I need to figure out how to get back to correct screen share here.
I had a question, Corey. If she could talk more about her vocal cord dysfunction, like explain what it is.
Carmen, are you comfortable explaining what vocal cord dysfunction is to us, or should we?
Yes, that's fine.
Oh no, I just screwed up the, okay. She can still talk from your
Vocal cord dysfunction is when the vocal cords close. Can you hear me?
Yes, we can hear you.
Okay, it's when, you know, when you breathe in, your vocal cords open to let the air in and let the air out. Vocal cord dysfunction is when the flaps close and they stop you from being able to breathe in and get oxygen in. And they say that if you quit breathing, you can pass out and your body will relax and you'll start breathing again. I don't know if that's true, but from the other people that I've seen with vocal cord dysfunction, a lot of people get hospitalized and get on ventilators because of it. Thankfully, I'm not that bad. The treating of my anxiety seems to have helped mine, and being able to realize where I'm at, and changing my environment when I start feeling the pressure helps me. But mine is stress. There's a lot of people that have a bunch of different stressors for it.
Thank you. Appreciate you answering that question for us. We're rejoining the meeting here in the room, so you'll be able to see the screen here again in a second. Marianne, can you let me speak?
Mm-hmm.
our slideshow back up. Figure out how to do the screen share. Great. Thank you, Carmen. Our projectors. Catching. Thank you, Gloria. It's kind of unfair to turn it over to you, Matt, make you do it without your slides. Just interpret it.
That's not something that
Absolutely handle it.
Corey, can I mention something you can see on that slide up?
Absolutely.
This is a screenshot from a 12-minute video interview with Carmen that's on the Alaska Resilience Initiative YouTube channel. So if you just go to YouTube and type in Alaska Resilience Initiative, you can find Carmen's story and share it with others.
Thank you. And thank you, Carmen, for sharing it with us. And now I'm going to turn it over to Dr. Hirschfield.
So first of all, I wanted to thank Carmen for that story. It was a pretty moving story for me to listen to because it does describe how stress can manifest as all sorts of different symptoms. And like she said, her physical body through all the scans and stuff are normal, but the stress that she's experiencing really affected her in a major way. And so that kind of speaks to kind of what I'm going to talk about. But one thing about this, Carmen, there are, I'm a pediatrician. I don't take care of adults, but there are pain specialists out there in Anchorage. And if you email Corey
Or Gloria.
or whoever, and they can give you my email, and I can make a recommendation for somebody if you haven't seen them. I don't want to give you medical advice for a bunch of people. Anyway, it might help. So anyway, thank you for your story. It really does show how the stress can affect all body systems. And so when I'm a pediatrician and kids kind of do the same thing that Carmen does, when they're under a lot of stress, they can come and see me, and they're coming for headaches, stomach aches, body pains, and it's up to me to figure out if it's something physical, like they have had an injury, stress, or something that's happening in their life that's really causing body pain that are happening similar to what Carmen described. And so this is mainly up there just to show you guys a couple of websites. Again, I'm a pediatrician. I don't do the adult stuff, but kids are manifest stress in different ways at different ages. So a 0 to 2-year-old has a very different way of manifesting stress and things that are happening at home that aren't conducive to that 2-year-old growing up very well, and a 3 to 6-year-old and a 7 to 10-year-old. So these two websites give you a really good listing of what you should be looking for as clinicians when you're thinking about a 0 to 2-year-old who might be having trouble. Like all of a sudden they're losing weight where they've been gaining weight really well. That can be a sign that things aren't going so well at home for the kid. Or a 3 to 6-year-old starts having new fears or like nightmares or something like that, or they start missing preschool or kindergarten. That's a kid who may be experiencing something not so great at home. And that's how they are manifesting the stress that's happening to kids. And for all the other ages, just check out those websites. There are also screeners that you can look at that kind of test families for stress at home. This is one of the common ones. It's a SEEK screener. There's a whole bunch of these out there. They're all free. They're all in multiple languages, none of which really affect us up here in Alaska as much, just like Spanish and stuff like that, but not Yupik or India. But they're pretty good. They're a decent way to kind of, for a clinician to kind of get at some of these issues with a family and start a conversation. But it's really easy on a screener when you come in to see somebody just to check out all the way down. And if, a lot of people are busy and they see a screener that says no all the way down, they think, great, I can just move on with my day and not really have to talk anymore. But this is kind of what I've started to use throughout my practice to really get at some of these issues a little more personally. I work over at Alaska Native Medical Center and screeners, and so conversation is a great way to get to know people, get to know patients, and get to know families. And so when I'm worried about a kid or worried about the family not doing so well, I start asking questions about how things are going. And these 4 questions seem to work pretty well. Now, when you first meet a family, they don't trust you, they don't know who you are, you're just some random guy from Anchorage who's up at Nome or something, and just kind of seeing people. But as you start to get to know family, one of the great things about being a clinician is close following and making sure that you can, you see a family once, you're a little worried about them, they don't really talk very much, or they don't really admit to anything that's going on at home. See them back in a couple of weeks, and then ask the same question again. First of all, it shows that you care because you brought them back and you start talking to them again. Second of all, as they start to trust you and they start to realize that you actually care about what's happening in the family and you're not just there to get through your day, they start answering these questions more truthfully over time. And so close follow-up as a clinician, as a primary care pediatrician, family medicine doctor, whoever, social work, all these, it works better the more you get to know. And so again, rather than doing a paper screener, these seem to work better to get to know families. So has anything really stressful happened to your child since the last time I saw you? That's a great question to get at. Something bad happened to the kid or something's affecting the kid. And if the kids change their behavior because of that bad thing that happened to them, that makes me really worried that kid's not getting the support they need to really get through that situation. And maybe mom or dad or uncle or whoever's taking care of the kid doesn't know how to handle it. They just need a little bit of coaching or some help. That's where people like Cicely can really come in and really do some great things with that family to teach the family how to handle stressful situations for the kids. If a kid's behavior hasn't changed, like let's say a kid was bullied or got beat up at school or maybe even had some physical or sexual abuse at home, but that kid has a great family, a great adult in the room. They are able to navigate through that situation with the kid. Even though this bad thing happened, the kid's behavior didn't change. That makes me think that family's probably doing okay. They may need a little extra support, but if the kid's behavior is still going pretty well, and the family's doing okay, and all that kind of stuff, then that's a family I'm worried less about. That the kid's behavior has changed, they're acting out at school, or they're having nightmares, or they're not sleeping. Those are things that make me nervous that the family's not doing as well. Another question. So a lot of families have experienced bad things happening back multiple generations. And so if you have a kid who experiences physical abuse, that can trigger memories of physical abuse in the mom or dad if they happen to have that when they were a kid as well. And so if the kid's behavior has changed and mom and dad suddenly remember all these memories that they didn't necessarily think about all the time, and now their behavior is changing so that they're not able to help the child through this situation, that's a family at very high risk, and they really need additional support. And you need to see them frequently, and you need to get them into services so that both mom and dad and the kid can all figure out how to navigate the situation. Those questions kind of get at big events that happen in a kid's life. But if families can't say the last time they did something fun with their kid, that makes me nervous that there's a little bit of neglect happening in the family. If all they can remember is that the kid was watching TV for the last 24 days since the last time I saw him, that makes me nervous things aren't going so well there. And that also is a family who needs some help. And then give me 3 words that describe your kid to you. If all 3 of those words are expletives or swear words or not very good words, that makes me a little nervous that maybe things aren't going so well with that family either. So if they're great words like it's fun and happy and blah, 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 that makes me think kids are probably doing better than if the words are not so great to describe them. If you do get, as a clinician, if you do identify something's happening in the family, the first thing you always need to do is assess for safety. Make sure that mom and the kid feel safe, make sure that dad feels safe, make sure whoever's in your office is feeling safe, that they can leave your office and go to a place where they're not going to experience something significant. So assess them for safety, and if they're not safe, you have to intervene right then and get them into a safe place. You can refer, like as a pediatrician, I use social workers and psychologists and all sorts of clinicians all the time to help meet the behavioral health needs of my families. And OCS, domestic violence shelters, all these kind of things are really helpful to get the families the help they need. The Alaska Child Trauma Center, Josh Arvidsson, who you guys probably know, he runs this great program here in Anchorage that helps families navigate toxic stress in families and toxic stress in There's another program out there called Help Me Grow Alaska that is a 1-800 number that can allow families to call, get a case manager assigned to them, and they will get families into services that they need. So lots of things out there to help families. The key thing for you guys as clinicians or whoever is to get them identified and then figure out what they need and then get them to that. And what we're really trying to do as clinicians and educators, whoever works with families, is trying to build something called resilience. Laura was talking about the resiliency, the Alaska Resilience Initiative, or RE. It's basically everybody has stress. Everybody's going to experience bad things in their life. And your job as a parent and as a kid is to figure out how to deal with it, and how to make it so that you can navigate that stressful situation so that it doesn't turn into toxic stress. It doesn't turn into something that negatively affects your life. You get through that stressful situation and you get to the other side and you go on and live through your life. And so for kids anyway, and again, pediatrician, I think about kids, the most important thing for kids to be able to navigate that stuff is to have an adult who's super confident around them when they need them. And that could be a mom, it can be a dad, it can be an uncle, it can be a teacher, it could be a campfire counselor, it could be anybody, as long as they're there for the kid when the kid needs them. And even if lots of bad things happen to kids, if they have that adult who teaches them how to navigate stress, there's lots of data looking at this. If they have that adult in their life who can help them navigate all that stressful stuff, they tend to do much better as they get older. And what they do is they're building protective factors into their life. So even if your ACEs score is 15, there's only 10 ACEs, but if it was 15, if your protective factors or your resilience factors are also high, often those kids do pretty well as they get older. So it's a combination of your resilience, and it's a combination of things that happen to you when you're a kid. Even if lots of bad things happen, if you had lots of resilience factors like a quality adult in your life and basically a safe place you could go to, even if it wasn't your home, you had a safe place, those kids tend to do better as they get older. So what we're trying to do as clinicians is build this resilience in kids and families, and if we can do that, we're going to have a lot healthier next generation of kids.
Is there a question period?
Yeah. Okay. So I just want to preface real quick that my role is a clinician, but I do work for the Alaska Child Trauma Center. So when I was putting this together, I was trying to figure out, role as a clinician, but also we're very trauma focused anyway at the trauma center. So hopefully this makes sense, and it very much kind of overlaps what Laura had mentioned earlier, but I'll give a little more details of what that looks like for a clinician. So the overlying goal that I have when a family or a child comes into my office is to develop a safe, trustworthy, and empowering environment for the client. And these are all different ways that I'm able to do that. So the first one, of course, is that trauma lens, understanding that when a child or family comes into my office, that they most likely have been through something, because of course we all go through something that's very traumatic or stressful. And so having that understanding of kind of what Laura said earlier, not what's wrong with you, but what has happened and how can I help. Providing physical safety, the one piece I always mention to clients, just an example, I always have my heater on, so temperature, if it gets too hot or if it's not warm enough in here, let me know. Or if you feel like I'm sitting too close to you, or if you would like some physical space. And then I'm always mindful of how close or how far apart I am from somebody. And then I always let them also choose where they want to sit, if they feel more comfortable sitting closer to the door or something of the sort, of course, depending on the family, but most of the time that's typically I give them those choices. And then providing emotional safety. I always talk to them about if something is uncomfortable or you're not feeling safe talking about it right now, let me know and we don't have to talk about it right now. That also helps them teach kind of their own boundaries around emotions and if they're having a hard time in that moment. Always reflecting and validating and normalizing their experience. So a lot of times when they come in and say, for example, a kiddo who had some aggression, right? Normalizing it in the sense of when we feel unsafe or we feel like our life is in danger, sometimes we feel like we have to fight back. Our bodies just do that. All human bodies do that. And so normalizing that experience for them. And then, of course, using the individual strengths to drive the psychotherapy treatment that we're providing. This can be really motivating for clients, and it gives this client-centered perspective that they're coming in and driving their own treatment, that I'm not driving their treatment, if that makes sense. And then, of course, giving them the choice throughout the course of treatment. So, you know, if we do an activity that you feel like isn't helping, or you feel like you're not enjoying, or is uncomfortable for you, let me know and we can try something else. And then the overlying role of a clinician in terms of throughout the course of treatment, of course, discussing confidentiality and the limits to that in order to maintain that safety for that client. So kind of what Matt had said, always assessing for safety, whether it's, do you feel safe going home if they disclose a traumatic experience, or if they're a threat to themselves or somebody else in terms of suicidal ideation or homicidal ideation, always assessing for safety. Of course, collaborating with interdisciplinary teams. I always find that there is so much importance to making sure that I'm always collaborating with the different teams. So like the schools, or a doctor, or psychiatrist, or you know, anybody who might be involved with that family. And then engaging and encouraging clients to choose their type of treatment. So of course, underneath the umbrella of psychotherapy, there's different types of treatment we can provide. And so talking to them more in depth of where they want to go so they can have that choice. Because a lot of times when clients, not a lot of times, all the time, when people experience trauma, it wasn't their choice to experience that trauma, right? So making sure that they get the choice in my office. And then helping them have a clear understanding of the psychotherapy treatment they're receiving. One other piece I didn't add on there, but also the other services we can also provide. And so they can, of course, pick where they want to go with that. And then, of course, we provide mental health assessments, we screen for trauma, and we direct psychotherapy treatment once they choose kind of where they want to go with it. And we're always making sure we're doing it in a caring and compassionate and empathetic way. And then I always like to inform and discuss diagnosis with my clients, and especially if it's related to trauma, I very much normalize those symptoms of, you know, when we undergo stress and when we experience stress, sometimes our bodies do this to keep us safe. And so I always normalize their experiences. And then we also provide trauma-specific psychotherapy. So that's another piece. Working in the trauma center, we provide psychotherapy that's specific to children who have experienced complex trauma. And then for myself as a clinician, I'm always making sure I'm continuing to get education on trauma or trauma-informed care. Because there's always new knowledge out there and new research out there that can help inform my practice and how I can best serve my clients. And I think that's going to be a really important piece moving forward, is making sure everyone's continuing education, because we're always evolving in the field of trauma-informed care. So. All right, thank you. Thank you. So Carmen already had a chance to share her perspective with us. Laura, is there anything you'd like to add on the role of patients and family? Is Carmen still on the line? Carmen, are you still with us? Is there anything you'd like to add? Ariane, can you see her?
I need to unmute her.
Here. Hi, I'm here.
Great. Carmen, is there anything you or Laura you would like to add at this point about the role of the patient and family in trauma-informed care?
I guess one of the things I would add is, you know, when they talk about generational trauma, especially in the rural communities, there are tons of generational trauma. You know, I was raised with my father, and he was sexually assaulted from a very young age that I didn't realize, you know, as I was being traumatized. And he was bipolar. He you know, self-medicated for years with alcohol and drugs. And then here I am, you know, I always knew that I wasn't going to become an alcoholic, and I became an alcoholic. And, you know, I'm recovered, and I want to break the cycle of abuse. And I look at my boys and I think, you know, am I traumatizing them in a different way now? Because I'm, you know, I have anxiety, I have vocal cord dysfunction, I have fibromyalgia, I have chronic pain syndrome, I have all these things that they see, and how am I traumatizing them? And it stresses me out, because I think, okay, I need to get better so that they don't carry traumas, you know, and that's from a level realization standpoint. There's a lot of them that don't have that capacity. And so when you're dealing with a child that has trauma, you know, you're not sure what their parents have gone through or what their parents have gone through. And so, you know, the alcohol abuse and the drug abuse and the violence and the sexual assault. I mean, you know, I'm not sure how it is in Anchorage, but here it's rampant, you know, when you talk about sexual assault. I mean, I'm happy to know that it's getting more vocalized here in, you know, bush communities, but there's still, you know, you're taught to be silent and to hide it. And I mean, it's a mindset that I wish there were ways that we could change it. You know, we have more resources now than we did when, you know, my aunts and uncles and parents, when they were growing up. So it's more exciting now to know that we have, you know, we're at the point where we can make real change, but we need to make sure that the resources are there for the real change to happen. Because, you know, mindsets, you know, they're passed down, and, you know, you could become the enemy even if you're trying to do good, because you're basically going to open up a can of worms that if you don't have a place for that can of worms to go to, especially the more rural you get, you could do more damage than good.
Thank you.
I so appreciate, Carmen, that you're able to come and talk today and willing to share this story, because what I love about the way Carmen shares is that she says there's no, you know, basically there's no room for stigma. Like, we can't heal if we have stigma in front of talking about this. And I think that's part of the role of the family and the patient, as well as the provider. The provider can reduce stigma by creating a totally judgment-free space. The kinds of language that Matt demonstrated for how you ask questions, but you have to be able to receive people without judgment so they can heal. But then on the community side, the family side, who we are as individuals, the ways that we normalize talking about this and say there's no way we can heal if we don't talk about it. And so that's something that we can all do, is just as private people in our communities, and talk to our children about it. You know, talk to our children about stress in age-appropriate developmental ways.
So we also want to mention that there are other team members who may be involved in trauma-informed care. Today we've heard from a patient who's also a family member, and I want to recognize that Our panelists are also members of our community and family members and possibly also patients when they're not wearing their provider or clinician hats. So above and beyond a mental health clinician, a social worker, a pediatrician, other team members might include case managers or care coordinators, those school district employees, public health professionals, for example, that helped me grow a program that Matt mentioned, as well as others. We can brainstorm on that.
Including traditional healers, they many people an important part of that care team.
And community members can have a role in this, whether or not they have an official job title as well. Recognize that strength. And it's just a short list of other considerations. We're a little short on time, so I just want to touch on these quickly. But when we're thinking about trauma-informed care, it's important to think about public policy. One example of this that's been in the news lately is the California Surgeon General instituting screening for adverse childhood experiences or ACEs for all public school students in California. We also have our very own policy example here in Alaska, the D105, which introduced language around using a trauma-informed perspective in all of the policies for at state level a couple years ago. We want to recognize that insurance issues and healthcare costs impact this, and that it's important that those policies be developed in ways that support trauma-informed care, influence people's work and their relationships. And here's where the public health side of me says it's important that we keep doing research to understand how trauma-informed care affects people and what sorts of treatment are most effective in addressing it in people who've already been traumatized, and then what we can do to prevent trauma in future generations, which includes that policy work. I'm a policy nerd, and advocacy. So there are many other things we should do. And now let's take a couple minutes for questions, and then we'll move into our group work time. Anyone have questions for our panelists? Natasha?
Oh man. I've been doing trauma work for a little while now. I'm kind of disappointed in the language that you used, sir. I felt like some of what you were saying was victim blaming. As far as assessing parents, assessing caregivers, that kind of thing. I'll give you a good for instance. You're saying, well, if the parent's stressed and then they're not going to be able to provide good care. Well, we live in the state that has the highest sexual assault rate in the state of Alaska, right? Half of all women, according to a study that's done by the University of Alaska Anchorage, half of all women experience domestic violence or sexual assault. And so what I'm hearing you say when you say if they can't show up right, is that we're expecting women to experience sexual assault or domestic violence and show up like rays of sunshine for their children. The reality is, and this was not addressed, and I'm also disappointed in that, there is a huge lack of access to services just in general across the state, even here in Anchorage. My question is, were any of these processes developed with stakeholder input? If so, what did that look like? As far as the Alaska Child Trauma Center, I work intensively with child trauma. None of my providers have ever mentioned that. I bet if I asked them, none of them would hear of that. So when was that established? Is there a wait list? Do they perform filial therapy? And for the Alaska Resilience Initiative, was that established or does it have currently stakeholder input? Those are all my questions.
Okay, so we have 2 minutes. You used up about 90 seconds of it. So which question do you want them to address first? And then you can, of course, talk to our panel.
Well, they could say, you know, it was established in 2016. Yes, it was established with stakeholder input. No, it wasn't established. I mean, these are pretty quick answers.
Okay, so Laura, when did the Alaska Resilience Initiative come into being?
2012 in one form, but 2016 when I came on board and made it, it's a totally open, publicly open state collective. So yes, lots of people there.
Specifically, how long has your organization been existing? So I don't have an exact answer on that. I just moved here, so I apologize for that. But I know it's been around for at least 10 years for sure. Do you know, Matt, for sure with the Child Trauma
It's
Center?
got
Okay.
10 years.
Okay. Okay, yeah, I know for sure at least 10 years.
And in addition to board of directors, they have a community advisory council
For,
for the Child Trauma Center.
okay. Is there a wait list?
No.
Do you perform filial therapy?
Yes.
Okay. Stakeholder input in your practice?
So stakeholder input, aside, so the 4 questions I was talking about, I think that's what you're referring to. Those are not evidence-based. They're not, this is just what I use in my particular practice. So the stakeholder input that I've got is just families that I've been taking care of up here for 15 years and how they've responded to those questions. And that's what I've got. I don't have any, it's not studied, it's not anything that's evidence-based. The SEEK questionnaire that I used before, that is an evidence-based questionnaire, but it's not been based in Alaska, it's been based in
There's a lot of challenges around validated instruments that were validated in other places, and other populations that have not been validated in either Alaska Native or American Indian setting, or in Alaska. I'm happy to have a follow-up conversation about that too. But now I want to turn us to our group work. Oh, I'm sorry, one more question.
Not really a question, just I wanted to say thank you, Gravy, for your time, and specifically Laura. I actually heard you talking on a podcast, a local podcast, a Crude podcast, about ACEs.
The Crude magazine?
Yeah, and I really appreciate you going on and talking about that. So, thank you.
I agree.
And I think we may have, several of us experienced just a really positive, on-topic moment just ago, and that even when you're the questioner, if you're the physician or the social worker, often you need to be careful of your tone when you're asking some questions, because it can set the receiver up with a defensive reaction to what's being said. If you're really just seeking information, you got to keep it neutral in the way that you present. And I think that was a great example of how that can be misinterpreted by people.
Well, you're a little pressed for time today, which means they're moving more quickly here as a panelist, and I think they would in their clinical cases, working with families and especially with children. I appreciate your comment.
Oh, I just have a question about follow-up care. You said that if you see a family and you feel like they need additional care, they're maybe not as comfortable with you at first, what's the rate of people that continue to come back? Because with distance and stuff like that, is that something where you're going and seeing people regularly? Like, how does that play out?
It can be. I've done house calls many times to go and find families and to see how things are going. And I've also, my main clinic, so I do a little bit of hospital work here at Anchorage, but my main clinic is up at Nome. And so to bring a family in is a big deal. You have to get them on a plane and let them know. But oftentimes the families are pretty okay with that because it does get them to Nome and they get to do shopping and that kind of stuff. And so my rate of return for families to come back, if I request that they come back, is pretty high actually.
Okay, cool.
That's especially true if there's someone in the family who is worried about the kid. The great thing about kids, there are many great things about kids, but one of the great things about kids is it really does bring families together around the kid, and there's almost always lots of people around the kid who are interested in that kid growing up well. So it may be easier for me to bring people back as a pediatrician than it would be as a family medicine or internal medicine.
Sure.
So that's pretty high.
So now we're going to ask you to work in your table teams, which is why you've got a table number when you arrive. To brainstorm about what the roles various disciplines have in providing trauma-informed care. And I'll keep this with the disciplines up. And then after about 8 minutes, we'll switch to talking about the benefits of working interprofessional as we do that. Table.
I did.
Yeah,
Yes.
okay. My nurse had a lot of good things about Alaska.
Oh, cool.
Yeah.
We're coming out. We're coming out.
Oh,
with
really?